This is a talk that I gave at the recent SWAN Trauma Conference. It's about the FAST scan and why I believe it still has a role in the assessment of stable patients with blunt trauma. Before we go into this topic in any great detail, first I want to review a bit of history. You see, the FAST scan has been around for a very long time. It was introduced way back in the 1970s as a screening test to identify not readily apparent injuries in our trauma patients with altered consciousness, intoxication, or other painful distracting injuries. Where the FAST scan has proven its worth, however, is in our unstable trauma patients, where the detection of free intraperitoneal fluid allows us to bypass CT and take the patient direct for urgent laparotomy in theatre. And it does this with pretty impressive accuracy, specificities of 98 to 100%, and sensitivities of 73 to 88%, depending on which literature you look at. For this talk, however, I'm more interested in the stable patient. But what exactly does that mean? This is the first group of stable patients. We've all had these guys come into our trauma bay. They're more interested in a clever hashtag for their Facebook profile picture than they are about what injuries that they've sustained. When we see them, it's hard to believe that there's actually anything wrong with them. But that's based on our pre-test probability, following a review of their mechanism of injury, their pre-hospital clinical course, and their primary survey. These patients don't need a FAST scan because our clinical assessment tells us there's nothing wrong with them. Then there's this next group of patients who have stable vital signs but positive findings on physical examination. We already know that patients like this will have an abnormal EFAST, so there's no point doing a scan on these guys either. We treat the patient clinically and arrange for investigations or interventions based on their pattern of injury. For me, stability is the combination of normal hemodynamics and end organ perfusion, combined with a patient who does not require an immediate resuscitative intervention. Unfortunately, even in these patients with patterned bruising and a high index of suspicion for injury, the value of the FAST scan is often brought into question. So, if we're going to ponder the usefulness of the FAST scan in these stable patients with blunt trauma, we must first have a look at some evidence. And I've selected just 3 papers that help support my view on this. First of all, there's this paper from a Level 1 trauma center in Nebraska. It was a 7-year review of their trauma database, where just over 2,100 patients had a FAST scan with a total specificity of 99% and a sensitivity that was below average at 43%. When they looked closer at just the stable patients with blunt trauma, their sensitivity fell even lower to 41%. This brings me to my first take-home message from this presentation. You cannot exclude a clinically significant intra-abdominal injury in a stable patient from blunt trauma based purely on a negative FAST scan alone. We have to ask ourselves then, what injuries are we missing? In this study, the contained hematoma of the spleen or liver was quite common, as was hollow viscous injuries and retroperitoneal pathology, particularly that of the renal tract. If you are going to call a scan negative, however, you really need to make sure that it was truly negative. The reason I bring this up is the FAST scan has some notorious gotchas, especially the caudal tip of the liver that you can see here and the diaphragmatic surface of the spleen. In patients with high index of suspicion for significant injury, one must pay particular attention to these areas of the scan and interrogate them cautiously. This second study was a retrospective cohort study from the Netherlands, where they reviewed the potential for risk stratifying hemodynamically stable patients with blunt trauma based on the use of their FAST scan. They'd scanned just over 400 patients in this study, with a total specificity of 99% or 14 positives, and again a below average sensitivity of 67%. In this study, I'm more interested in this positive group, you see, because out of these 14 patients with normal vital signs and a positive scan, 2 went urgently to theatre for a laparotomy, 3 went to interventional radiology for urgent angioembolization, and 1 poor patient died in the emergency department before definitive care could be arranged. The positive fast scan in these stable patients predicts inpatient morbidity and mortality, and it does so with a positive likelihood ratio in excess of 30. In this study, the fast scan performed more reliably than the injury severity score in predicting bad outcomes for patients. Finally, there's this paper from UC Davis in the US, a level 1 trauma center reviewing their trauma registry database over 6 years and looking at the utilization of the fast scan in predicting the need for laparotomy in their stable patients. Just under 4,000 normotensive patients of blunt trauma were included in this study, and these guys knew how to scan, a specificity of 96%, but an impressive sensitivity of 85%, some of the best that you'll find in the literature. Again, if we focus in on the positive scans in this group, we'll see that almost 60% of these stable patients actually required a laparotomy. And there was a correlation between the volume of free fluid found on that fast scan and the need for actual therapeutic intervention at that laparotomy. So, if we go back to the beginning and ask ourselves, is the fast scan a worthwhile modality in our stable patients with blunt trauma? Well, firstly, if you're trying to exclude an intra-abdominal injury in a stable patient by using a negative fast scan, well, your clinical judgment would be more accurate if you were to flip a coin. However, if your fast scan is positive in a stable patient and a blunt mechanism, well, that ultrasound has just become the canary in the mine. It's an early warning system that identifies a patient who is either likely to deteriorate or likely to need a significant surgical intervention in their first short while in hospital. There is no doubt in my mind that ultrasound makes us better clinicians. Over the past 40 years, ultrasound itself, however, has been in a state of evolution. We can measure optic nerve sheath diameter in our head-injured patients as a predictor for raised intracranial pressure. We can identify pubic symphysis separation in patients with suspected or confirmed pelvic fractures. But more impressive than this is that ultrasound has found its way outside of the four walls of our resus room. It is being performed out on the roadside by our pre-hospital and retrieval physicians as well as our advanced care paramedics, even performed on patients who are still trapped in their vehicles. The fast scan and advanced ultrasound techniques are even being performed at 4,000 feet and up to 400 kilometers away from the major trauma center. One such case that highlights this use from our service involved an Army cadet vehicle that rolled on a straight stretch of road some 200 kilometers northeast of Canberra. Coming across a scene like this with a few dozen young patients, all with stable vital signs but some pattern bruising and some abrasions, the use of ultrasound at a scene like this would help us to determine which of these guys gets priority for aeromedical retrieval to the major trauma center, ideally before they deteriorate. To finish my talk, I'd like to share with you one of my own clinical anecdotes, which I think highlights my stance on the use of fast scans in these stable patients with blunt trauma. For now, I'd like you to join me on a shift at Sydney Hems. You see, it's late in the afternoon on a public holiday weekend, and the bat phone calls for our attention. We're being tasked to a tiny town of Bircher in central New South Wales for a single car rollover MVA. As we're putting on our flight suits, the pilot tells us that we're 88-minute flight time from scene. During this long but scenic flight, you hear of a single vehicle that's left the road in excess of 100 kilometres per hour. It's tumbled 2 or 3 times before landing through a barbed wire fence some 30 metres from the roadside. There are 4 victims at this collision, but 2 of these are being taken back to a major trauma centre by a colleague in another rescue helicopter. As you land at the scene, you are directed towards the driver of this vehicle. Whilst restrained at the time of the accident, he was ejected during the rollover and found himself some 10 metres from this car. He has had a transient loss of consciousness, but is now alert and cooperative, and is complaining of significant right-sided chest pain and air hunger. On your primary survey, you find a patent and protected airway, with some dried blood around the oropharynx that you think might be hemoptysis. He's quite tachypneic at 32 breaths per minute with significant increased work of breathing, and despite supplemental oxygen, he's hypoxic at 94%. He has minimal air entry on the right side and diffuse tenderness along the rib margin. You hear the occasional crackle at his right base only. Hemodynamically, he's tachycardic to 120 beats per minute, but he's normotensive and has no external hemorrhage. Clinically, he has a proximal femur fracture on the left side. He's neurologically intact. What do you do with a patient like this? He gets a cannula and some titrated analgesia, but clinically he has a significant right-sided pneumothorax. How do you treat him? We have more than 90 minutes of transit time from scene back to the major trauma centre. And to get there, we have to cross the Great Dividing Range at an altitude of over 7,000 feet in an unpressurized cabin. Do you intubate this man and place a tube thoracostomy? Does he get local anaesthetic and a tube thoracostomy at the scene? Working for us at Sydney HEMS, however, we've got an ultrasound in our aircraft, so we perform an E-FAST. On that right side, you see clear lung sliding, both anteriorly and throughout all lung fields on that side. Supplemented with a seashore sign on M mode in all of these regions, you confidently exclude a pneumothorax. But because you use ultrasound in your medical practice as well, you astutely identify B-lines at his right base. These confluent bright lines extending from the pleural surface can also be seen at a greater depth of field and signify interstitial edema, something that you normally see in your pulmonary edema patients, but are focal to the right base in this trauma patient. Not only have we excluded pneumothorax in this patient, but we've identified the cause for his hypoxia. We've identified his right pulmonary contusion. So he gets titrated analgesia, and we calculate we have enough oxygen reserve on the helicopter to get him safely, spontaneously breathing to the major trauma centre. Over the next 2 weeks, the only reason for the patient to be intubated was to facilitate his orthopaedic repair, and at no point does he require intervention on that right hemithorax. There is no doubt in my mind that the use of ultrasound on this patient allowed us to deviate our initial clinical assessment and avoid performing what turned out to be an unnecessary invasive procedure. So if we go back to the beginning and ask ourselves, is there a role for the FAST scan in assessing stable patients with blunt trauma? I say absolutely yes. It allows us to triage, something that you can all do on your next busy emergency department shift in prioritising your trauma patients for advanced imaging, or that you might need to use at a mass casualty scene in the pre-hospital setting. Ultrasound allows us to enhance our communication from scene to the emergency department and from the ED to our subspecialty colleagues. But most importantly, the fast scan is the canary in the mine. The identification of free fluid in a stable patient with blunt trauma flags them as having a significantly higher morbidity and mortality and a need for therapeutic intervention. We identify these patients as high risk and we can act on them aggressively should they deteriorate. Thank you for your attention.